Hello, everyone, and welcome to today's live broadcast, Precision Medicine in Pharmacogenomics in Community Pharmacy and Primary Care Setting, presented by Amina Abubakar, CEO, President, RX Clinic Pharmacy, Avant Institute of Clinicians. I am Kaylee Bach of LabRoots, and I will be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the Ask a Question box located on the far left of your screen. Type your questions into the drop-down box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, please click on the Help Desk button located in the promotional board at the bottom center of your screen, or use the Ask a Question box to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located on the top right corner of the presentation window and follow the process to obtain your credits. Please join me in welcoming Amina Abubakar. I will now turn the presentation over to her.
Thank you. I'm delighted to be here today, and I would like to go over the objectives of today's presentation. So the goal is for us to identify the 3 approaches to pharmacogenetic testing for patients and describe the workflow in each model. I would like to list questions that you could ask a partnering lab to see if it's a good fit for your pharmacogenetic program. We will look at least 5 drug gene implications that we have seen mostly either in primary care or community setting, and what resources you can use to back up your guidelines or your recommendations to other healthcare professionals. All right, so the precision medicine, we are looking at it as the future of individual medicine, and it's exciting. Patients are learning about it, and they're looking for this information. And my goal is, as community pharmacists, either in primary care setting or in community setting, are we ready to take these questions from these patients and guide them to where they could find answers to some of their questions about precision medicine? Looking back, it was President Obama's State of the Union address, and he felt like if it's United States, a country has gone to the moon, it's time for us to look and see how we can treat patients with precision. The drugs we design are not for everyone, and we've always known that. But having this elegant science available, how do we bring it to the American population and around the world? The National Institute of Health has been conducting research since the whole genome project. And the breakthroughs of these treatments are crucial when it comes to individualized care. But the question has been, how do we get the population to engage? So there are a lot of questions that I face as a pharmacist when patients say, should I participate in research with the National Institute of Health? Why does the government need my DNA? So these are questions that we can answer to our patients, so that way we can help the initiatives at NIH. If you look at the FDA, if you go to fda.gov, lots of medications are there with guidance and the encouragement that these warnings about different genetic implications are now going to package inserts. And this list is growing every single day as we get more information. I was fortunate to participate at an open forum with the FDA. And the question that was being asked was, what are the best practices to deliver this information to American public? And when I was there, it was an interesting panel, and we had physicians, they were genetic counselors. And if you think about the role of FDA, and they want safety for the American public. However, we don't have a full infrastructure, that the entire bridge has not been built for us to be able to get the patient to do a test and have a provider that's available to go over the utility of this test before the patients get results. Because we do see there's a lot of direct to consumers, and my thoughts are, how much do they know about the power of this information? Because I've had patients come to me and they have their DNA swabbed. They can understand the ancestry part, but then if you look at the other sections, there's some CYP enzymes, and it's telling a patient they're a rapid metabolizer or a non-metabolizer of this enzyme, and those patients pass through that page and they have no idea what it means. So the only thing I see is that pharmacists need to step in this space and become those healthcare professionals that can tie the gap from a provider to a patient and be able to counsel these patients in our communities. After the FDA, I was fortunate to be invited to the White House Office of Science and Technology to have these further discussions. And that's why now I do a lot of lectures and webinars to allow other pharmacists to enter this space so we can close the gap and have this elegant science really taken up and clinical utility seen in our outcomes. We can now go to the background of the science of pharmacogenomics and what it is. So the definition is the study of how genes affect a person's medication response. And the thing with genomics is that it has to take into consideration the pharmacology on top of the genomics if we want to get an entire precision medicine response. Many people have talked about which term is the most appropriate. So pharmacogenomics, when we use the word genomics, it's more broader. So it really takes into consideration all the genes in the genome that determine drug response. And when we look at the pharmacogenetics, it's more narrow, and it's generally used in relation to genes that determine the drug metabolism. So these words can be used interchangeably. The sources of variation in drug metabolism, it's not just genomics. So genomics is one piece of the puzzle, but it's very important to understand drug-drug interactions, environmental factors, disease states, and other factors like age and gender that affect a patient's drug metabolism. This becomes very important because a patient may look at a report that says they should be a normal responder and they should be able to expect outcomes, but failing to look at other drugs that are on board for the patient that could cause drug interactions, it won't be justifiable for us to say this is all precision medicine just because the person has the right genomics. Which leads me to a term called phenoconversion. So phenoconversion is a phenomenon that converts a person's genotype, what we expect, to a totally different phenotype. For example, we get a report for a patient and it tells us they're an extensive metabolizer, therefore they're normal in metabolizing this prescription drug. However, because of either a disease state or another drug on board that can affect how this gene would now respond. So the phenotype of the patient would now change. So phenoconversion is very important, and that's why I believe pharmacists have to be on board because of their extensive drug-drug interaction knowledge. So if they work with medical providers who have the medical knowledge and disease state, we're able to come together and help a patient in precision medicine. So drugs are currently available as one size fits all. And as a pharmacist, I have seen several patients come on board with a particular medication, either for them or their child, and a few weeks later, we're on a different medication. And we've always known that not every medication is for everyone, but we never had a tool. We never had a tool that could justify which patients we should avoid certain medications. Looking at some of the statistics where we're spending $136 billion annually on adverse drug-related events. And these are medications prescribed correctly, and the patient was taking them as prescribed. But the serious effects they got and got hospitalized were that the patients were not appropriate candidates for these medications. So what are the benefits to a patient? This process eliminates trial and error prescribing, and it helps them control the cost. Because as a pharmacist, as I look at those patients who came in and had the first prescription that wasn't the right one, had to have another visit with their medical provider to get prescribed another medication, still as a trial and error, for us to make sure that it will work, there's cost associated with it, and there's the chances of potential adverse drug events. And what I've also enjoyed is looking at the confidence and peace of mind for a lot of patients who feel like, okay, now that I know psychologically that I'm taking the right medication, patient seems to have confidence and higher rates of compliance. What are the benefits to medical providers and pharmacists? So this provides us with a baseline. I mean, medical providers are healers. When patients go to them, their goal is to help them alleviate whatever condition that they've come in for. So when we can get a baseline for guidance, it helps us to initiate the right medications right from the start. It saves the physicians a lot of time with patients coming back and forth to get optimized in a drug therapy. And again, that's the whole eliminating the trial and error prescribing, and it promotes patient adherence. A lot of my patients, when they pick up medications, they'll read a lot of those side effects that might happen to them on a package insert. So this has become interesting when they look at, oh, this is the medication I can take. They've not been really concerned about all the other things that may happen because they have confidence that they're starting with the right medications. And it's also providing additional innovations for medical practices and expanding revenue, potential revenue. So when we get the results, this is an example of an extensive, or what we call a broad spectrum panel. And you can see, depending on the model that you use, whether you are going to be looking at entire spectrums or a specific gene pool for a specific disease state. But this is an example for a broad spectrum where you have the test results and you have the genes, you have the genotype of the patient, you have the phenotype. That means how they are showing up, whether it's a normal metabolizer, poor metabolizer, and you see all the alleles tested. It's important to look at the alleles tested because some results could show a patient is normal metabolizer, but the allele tested was not an entire pool. So if a lab misses out a particular allele, it shows up for a patient that the patient is normal. And I've seen this with several patients that had they had two different labs perform the test. And in one lab, the patient was normal. On another lab, the patient was not normal. So that's when it told me the importance of pharmacists or medical providers being aware of prevalence and looking at the alleles being tested for these patients. So knowing that the panels can give us all this information, the question really becomes, should we get all the information up front? Or should and get a broad panel? Or should we wait and see which patients need a particular gene panel? Let's say if a patient who's going through depression, do we only pull the genes that are related to depression and not necessarily look at everything else that we could know up front for the patient? Which leads us to the different approaches. So I've seen approaches of what we call preemptive. So preemptive is where an individual who may or may not have any medications on board or any medical conditions that they're concerned about, but as a wellness tool to have a blueprint up front of what medications should they be needed would be good for them. So you can look at this as cost saving because it's the same swab that could give us 1 gene or 25 genes. And also the other advantage of looking at preemptive, it avoids a major delay when a need arises. For example, no one's immune from depression, no one's immune from pain management, because an incident can happen in one's life. And how long would you need to get these results back to get initiated the right medication? So that's how we look at preemptive. Semi-preemptive is where you're selecting a high-risk patient population and then initiating the particular test. For example, if you have a patient that has high risk for cardiovascular events, then getting information on medications that are related to cardiovascular could be beneficial. Then we have reactive, and reactive, I've seen it where once a patient has failed several medications, now we go back to look at let's do the DNA test and see where we go from here. So these are the different approaches, and of course they're all justifiable based on cost because everyone doesn't have the same affordability, can't afford the test. So you would have to use that judgment in your practice to see when you talk to patients, are they able to see the value of all three and then make a decision. So drug metabolizer status, and this is what shows up in most reports. So you'll see a poor metabolizer, and this is where 2 non-functional alleles, basically they have little to no enzyme activity, and these patients will be classified as poor metabolizers. Then we have intermediate metabolizer, where they have 1 functional allele and one that has decreased functionality. So they would be intermediate. Then extensive metabolizers are also known as normal metabolizers. And these are patients that have 2 normally functional alleles, and we're going to expect normal enzyme activity. Ultra-rapid metabolizers, they have 1 or more alleles that have increased enzyme activity compared to a normal or what we call extensive metabolizers. Now, why is prodrug versus active drug important? So when patients are reading these results that say you are a rapid metabolizer, and then it tells them they need a lower dose, then they look at another drug, it says they're a rapid metabolizer and they need a higher dose. So patients feel confused in understanding why could the same status give them 2 different results. So that's why I say it's very important for pharmacists to educate their team members or patients about looking at the drug itself. Because if you're a poor metabolizer of a prodrug, that means you are not activating it. Excuse me. So you're not activating it, and therefore you're going to have a different response. But if you're rapid metabolizer of an active drug, that means you're clearing it faster, so you may need a higher dose. So understanding this becomes a fundamental clarity for our patients, because a lot of them rely on Dr. Google. Here's an example of that results. So you have where it says amitriptyline, and the patient is a rapid metabolizer for amitriptyline. It shows that the patient has increased sensitivity. Consider an alternative drug. for this patient. Now, if you look at that, and it also says citalopram, the patient is going to have insufficient response, to citalopram, yet they're a rapid metabolizer. So this is a clear example of how this shows up in the results and why it's important for a patient to understand that amitriptyline is a prodrug and citalopram is an active drug. Transporter functionality. So when we look at all the enzymes involved in drug transport, it's important to look at the statins. For the longest time, we've avoided high-dose statins because they do cause myopathy. But in the world of precision medicine, understanding not all patients are at risk of myopathy. Now we can see patients that have specific enzyme reduced activity may be subject for this, because we have the medications that are absorbed into target tissues more efficiently using the transport enzymes, and also they have to be removed from these target tissues using the transport enzymes. So looking at a patient's genetic results and looking at those transport enzymes, this would allow us to dose statins more precisely. So what are these clinical resources? When I first got into this space, that's what my medical providers needed. They said, yes, great, Amina, this elegant science, I'm sure we can help our patients, but how do I validate this? So 3 years ago, this was brand new, and there were not a lot of resources out there that the medical providers in my community were aware of. So it was my responsibility to start searching for what are the databases that we could find and validate this information. It's one thing coming from a lab, but it's another thing a prescriber or a medical provider, a pharmacist, validating these results for themselves. So here are some of the resources: CP guidelines and PharmGKB. And also there are other resources like the Dutch Pharmacogenetic Working Group and the Canadian Pharmacogenomic Network. But for what I have extensive experience with is the CPIC guidelines. They're considered as the gold standard for evidence-based clinical guidelines. And it comes with different evidence level. So you can see a study with the results, and it will tell you whether this is strong or moderate, which helps a lot of practitioners make better judgment of their drug therapies for their patients. And this is a link for PharmGKB. It's also an online database. It has dosing guidelines, drug labels, and it also tells you about the actionable gene-drug results, and it shows you the genotype and phenotype relationship. So these have been great resources, and I hope you guys would find them beneficial as well. So looking at best practice for integrating this pharmacogenetic in our pharmacy or in most pharmacies, we consider the best fit for it is an MTM, which is the medication therapy management. Because right now, pharmacists are charged to perform medication therapy management. So we sit down with the patient and we look at their current medications, we look at their disease states, and we help to close the gaps in care. We find patients that are not in appropriate medications. They see multiple providers. Maybe we see duplication in therapy. There's opportunities for cost effectiveness because patients can't afford their medication, so they sit down with a pharmacist to look for alternatives. However, what we're recommending is based on if you could take it, if you were the right candidate. So we've discovered if we could add the component of pharmacogenomics, now we're not just making recommendations based on one piece of the puzzle. So it feels good to know that I'm converting a patient from one medication they cannot afford to one that they can afford, but they're also the right candidate for it. Another best practice is medical provider relationship. Pharmacists are not there to replace the medical providers. It's more about collaborating. It's easier to coordinate care as a team. And as pharmacists are knowledgeable with not only the drug-drug interaction, the pharmacogenetics, and now having extensive information in pharmacogenetics and using evidence-based guidelines, they become extenders for medical providers, because with medically complex patients getting these results, it's time consuming for the providers to go through all the gene drug implications and come up with appropriate therapies, but also take into consideration the drug-drug interactions before they make all these choices. So it frees up medical providers, and also technology is being built in the pharmacies now where we can house this information. And if we are to fill a prescription for a patient that is not the right candidate for it, and the insurance requires prior authorization, this becomes a great tool for the provider to send to the insurance company or the third-party biller to show that it's not the doctor prescribing a medication that's not on formulary, but we have results showing that the patient is not a candidate for what's on their formulary, and therefore getting a prior authorization for non-formulary medication. And having this collaboration relationship, it will keep the population safer, because if we can avoid direct to consumer, we can introduce a group of healthcare professionals that are located in every 5-mile radius to an American. So patients can have access to a knowledgeable provider who can help them make the right judgment. And so patients are not stopping life-sustaining medications because it appears on their results as they should not be on it. Sometimes we have to have that conversation that you have already been adjusted for. You know, yes, you were titrated up and down, and now you're having outcomes. Because, and I've seen this firsthand when patients say, why was I put on this medication and I could not take it? But they're having great outcomes. They're not experiencing any side effects. So we had to explain to them that we've talked to their medical provider, and none of their medical results or their labs show that they're at risk. So at this moment, they have been adjusted to the appropriate dosage. So in order to offer this, you have to have the lab partner. And there are many labs out there that do it. The most important thing is to look at what your organization is looking for in terms of infrastructure. There are some health systems that already have genetic experts. So all they need is a lab that can process. And then their genetic expert can serve as the clinical support and drug information. But then we meet other providers that are ready to get into this space, but they don't have that infrastructure. So in looking for a lab, it will be important to understand your internal needs assessment and see if those labs could be a partner to offer you education, training, clinical support, and drug reference support. What panels do they offer? There are some lab partner that would only do a specific gene pool, and there are others that would do a broad spectrum of genes. So that would be a good question to ask. And make sure the labs are certified by appropriate governing bodies so you can rely on their data as well. So back to performing the medication therapy management, or what we call the personalized medication therapy management, because now we've incorporated their genetic information. And if you look at this, this is what we've always envisioned as medication therapy management, where you have the pharmacotherapy, you have the disease management, whether it's anticoagulation, whether it's medication safety, patient's immunization, and having this fit in, it's very timely with value-based care. We are now in a value-based delivery healthcare model. So having this information, I feel, is playing a huge role as we want to lower our hospitalization due to inappropriate medications, and we want outcomes for our patients. So I felt like this was very timely. So patient education material, if you're a pharmacy that is getting into this space or a medical provider, it's good to create graphics that patients understand, because once they receive this information and they are no longer at your practice or they travel somewhere else, they still have that visual of understanding the value or what we call the utility of their test. So there's many ways. This is just an example how you would create patient education material and have them understand what they're purchasing. Performing the test has been very simple. Mostly in community pharmacy, we've seen the chick swab approach. So it's a chick swab on each side, and then the results are sent back to the lab. And it's been an average of 3 to 5 days to get the results to come back. Then you get the results, and now you set an appointment to go over the reviews. So again, it's important for the patient education component. Sometimes patients feel that now that they have these results, they shouldn't experience any side effects. So that's where a pharmacist is very valuable, because, and I tell a lot of my patients, no, we expect you to get the right outcomes. For example, if you took a prescription medication that is supposed to make you drowsy, it will make you drowsy. So if they consider drowsy as a side effect, then they want to take a medication that is on their appropriate genetic outcomes. However, they don't want to be drowsy. So this is, it's a very important time when you sit down to do these reviews. And it's also important to go through the disclaimers about the test, that pharmacogenetic versus precision medicine. So pharmacogenetic is where, yes, this is your gene results, and this is what it says you would expect. However, let's look at your renal clearance. Let's look at other medications being on board. Let's look at your allergies. So there are a lot more things to call it completely precision medicine. And always include the medical provider, because they have the full picture of the patient. I say it's the best practice. Patients can approach you in the pharmacy and say, I would like to have this test done. But really, to have results back and their medical provider who sees them for their care is not aware that these patients are doing this test could really compromise the patient-provider relationship. So we've always found it a way to call the provider and let them know that their patient's interested in this, and will it be okay for us, once we get the results, to share with them? Because if you have findings, you're not their direct medical provider. You cannot initiate, you cannot just adjust medications. So the collaboration is key, and I do let the patients know that. So in the checklist, you go through, confirm their current medications, and also, as we talked about, counsel on anything else that a pharmacist is able to. Talk about their preventative care counseling, and looking at the evidence level to make sure the results that are being acted upon are those that have actionable data, and coordination of care with their providers. Also try to understand the limits of the reports that you have. What does the lab do with medications not covered on the testing panel? Because when a patient fills out the form, they fill out all the medications, and then they're expecting to get results of each one of the medications. So how does the lab address those medications, like hormones or other medications that they do not cover? So do they just say the patient's okay with it, or do they specify that these medications do not go through the genetic pathway? Does the lab consider the different dosage forms? Do they look at oral, parenteral, topical? How does the translation software interpret the guidelines? You know, so when they're giving results, what are they putting in terms of what's actionable? You know, where are they getting their data from? And also, we found some of the limiting factors of their translational software that don't take into account all the pharmacogenetic data. And we found there was lack of pharmacogenetic data for ultra-rapid metabolizers, for rabeprazole. So it's good to look at the limitation and compare with other PPIs, as far as other proton pump inhibitors, just to see what metabolic data shows up on those portions of drugs. Most results come as a red, yellow, and green. But again, as healthcare professionals, we want to make sure to encompass everything of precision medicine, and green doesn't necessarily mean go. We do have to look at other aspects of the patient and other medications. So let's look real quick about examples of disease states that seem to have had an impact in community settings. One is pain management. No one's immune from pain. In the United States, we have a huge opioid epidemic. So pain management is key in terms of helping patients to be on the right medications right from the start. There are major genetic contributors to opioid therapy, and I'll go through CYP2D6 is the most important enzyme to look at when we look at codeine, especially. So codeine goes through a pathway, and without the conversion of CYP2D6 pathway, patients are only getting the antitussive effects of codeine. In order for them to get analgesia, it has to go through the CYP2D6 pathways, which gets converted to morphine, and that's what gives them the analgesia. Otherwise, patients are only getting the antitussive effects. We've seen a lot of case report, and this is where it becomes so important. For example, there's a black box warning for codeine right now in children. However, understanding this genetic pharmacogenomics, codeine is a great drug if we give it to the right patient. So it's not like I don't believe it's a full ban, because if I look at there's a few case reports. You have a 2-year-old boy that was discharged after getting their tonsils removed, and they were sent home with codeine and Tylenol. They died on the 3rd day post-surgery, but when they did get the cause of death, patient was ultra-rapid metabolizer of CYP2D6, and the codeine level was 0.7 milligrams per deciliter, but the morphine was 32 nanograms per ml. So that 2-year-old boy received morphine at lethal doses. So it's not that the codeine was bad, but the patient themselves were an ultra-rapid metabolizer of CYP2D6. So they just converted it all to morphine. Same to the 4-year-old boy that was discharged after an overnight stay and was sent home with liquid codeine, and they had morphine toxicity. Same to a full-term infant that died 13 days later because the mother was an ultra-rapid metabolizer that was given Tylenol number 3, which is, when you look at the categories of breastfeeding, it's appropriate for the mother, but what the mother passed into the milk, because they were a rapid metabolizer, was morphine. So the baby received morphine. So looking at these case reports just tells us the significance of really embracing pharmacogenomic and making clinical utilities out of it so we can prevent unnecessary deaths like this. So if you look at CPIC recommendations, for the sake of time, I just wanted to show that it does classify for the ultra-rapid, normal, poor metabolizer, what they would consider as alternative. The prevalence, African or Ethiopians have a higher ultra-rapid phenotype. And this tells me in the future, it wouldn't matter what race people are that we normally stratify for risk factor. We would need to know the specific genetic pool so we are able to treat them accordingly despite of a geographic area. And if you look at the different races here, from Caucasian to Asians, you'll see the prevalence of poor metabolizers. So you have patients that receive pain medications, but they come back to the pharmacy and say, this doesn't work for me. And unfortunately, there's a stigma around opiate abuse. So you have these patients being categorized as, oh, they're drug seekers. But actually, if we had their genetic information, they're probably poor metabolizers. And so they are not converting, they're not going through the CYP2D6 pathway to get analgesia. Another category is cardiology. And when we look at cardiology, it's a high-risk disease state because it causes from stroke to death. And when you look at this, clopidogrel and warfarin are the top drugs that we really look into, especially for patients that are either undergoing, they've already had a stroke before, or they're receiving a pacemaker, so they've had triple bypass surgery, and now we want to prevent cardiovascular events. So these patients, if we do not get the right information, they are going to get an event, and they will be back in the hospital or even cause death. So the Centers of the CMS has this cardiac bundle payment, and this is all coming back to value-based medicine. MACRA is the law that does that. And so it's supporting new payment and incentives for hospitals to reduce readmission. So this is very this is very useful for hospitals that have cardiac units. It will be beneficial for them to make sure they have the CYP2C19 is the enzyme really involved in the clopidogrel, to make sure patients being prescribed that are appropriate, because they did a study, and that the poor metabolizers and intermediate metabolizers for CYP2C19 were readmitted for a thrombotic event within 60 days of initiation. So this is a very appropriate test. And even if these cardiologists are only interested in CYP2C19, this could really meet their incentives of readmission, reduced readmission, with patients that are intermediate or poor metabolizers. And again, the CPIC guidelines would classify the patients and would give alternatives for the antiplatelet therapy. And these are the prevalence. You can see Caucasians, 40% ultra rapid. If you're ultra rapid metabolizer of CYP2C19, because clopidogrel is a prodrug, that means you're converting it to the active format fast, and you're at risk of bleeding. And then if you're a non-metabolizer, then if you're a poor metabolizer, then you're not converting it at all. So you have high chances of having those events because you don't really have an active drug on board. Warfarin is key because there are two components to be looked at. So it's CYP2C9 and the VCORC1. So when you're looking at warfarin, both these genes have to be looked at together in order to come up with dosing guidance. And FDA has the recommended daily warfarin dose based on the VCORC1 and the patient's CYP2C9 genetic results. And here's an example. Beta blockers are, again, back into cardiology. The enzyme involved we're looking at is CYP2D6. And the most important thing is patients who have extended beta blockade because of being exposed to metoprolol. So looking at which medications for patients that are going to have the variant, and the most important variant in this CYP2D6 is the STAR4 allele. So in the absence of this activity, patients have had a higher exposure to metoprolol, and they have had decreased heart rate that have taken back into the hospital. So alternatives for this would be the beta blockers that do not require the CYP2D6 pathway, and that's like the bisoprolol, atenolol, carvedilol. And these are some of the guidelines when it comes to the CYP2D6 and metoprolol. Statin-induced myopathy, I had referenced it earlier, where patients may have myopathy, But now we know that it's not every patient that gets myopathy. It's patients with reduced activity for SLOC1B1 gene. That's the transporter that gets the statins out of the muscle tissues. So if they don't have a functioning SLCO1B1, then they are more likely to experience rhabdomyolysis. And here is a chart from the CPIC guidelines that would allow you to dose patients based on their results. Neurology, we look at carbamazepine as a drug at this moment. Patients with Asian ancestry, they have a high prevalence of a positive HLA-B, and this really exposes them to a Stevens-Johnson syndrome. So if you are in a high population of Asian descent, this will be a medication, whether it's being treated for epilepsy treatments, that if this is a drug of choice, these patients would highly benefit for being screened for the HLA-B. And these are strong evidence from the CPIC guidelines when it comes to carbamazepine. Antidepressants are huge because patients, this is what I've seen the most, where patients are different medications before we can get it right. Already we knew we needed 6 weeks for us to get results, but now imagine 6 weeks on a wrong medication, and then you have to get another one and we wait 6 weeks. And these are patients that really need immediate relief because we've always heard of warnings that antidepressants, be careful, they could cause suicide. So my question is the antidepressant causing suicide, or are we giving patients that are depressed medications that are not the right medications for them? So technically, they're not taking anything and then they commit suicide. So that's something I've always thought about in the community setting, as now that we have this information, I believe this is one huge disease state that we could at least make sure the patients are on the right medications. Antipsychotics and ADHD, and I'll just go back, the enzymes that we're looking for in antidepressants is the CYP2C19 and some of the CYP2D6 as well when we get to the medications that are with the antipsychotics. So antipsychotics, ADHD, ADHD medications are very similar in using the CYP2D6 pathways. So looking at each medication and making sure that the patients are on appropriate medication. So when I work a lot with parents with ADHD children, and this is a painful point for them where the medication is either too much and the child is just zoned out completely, or they get calls back from the school where there's a lot of hyperactivity. And then the cost associated with taking time away from home, from work, taking the child back to the doctor, getting on the different medication, and not having expected results. So we found this to be extremely beneficial for those patients. Any questions? Thank you so much for your time. Hope you've enjoyed it, and I encourage any questions right now.
Thank you, Amina, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question drop-down box located on the far left of your presentation window. Type your question into the box that appears on your screen and click the Send button. We'll answer as many of your questions as we have time for. Let's get started. Our first question is, does insurance pay for this test?
Great question. So when this first came into the market, the insurance were paying for it. And then slowly after that, because they were paying for broad spectrum, and if you look on the insurance point of view, is that they may not have seen immediate ROI. because this is mostly a preventative tool. So with that in mind, they've now come for a narrow group of patients that they would pay for, patients who failed some antidepressants, patients who failed some pain medications, and also patients who are undergoing anything with cardiology, they would pay for. So it's more of a specific disease state, or what we say specific diagnosis that they would pay for. But it's coming back in the market as more research is coming in and more data is available for them to justify their ROI.
Great. And our second question says, would a patient need to be swabbed again if a new drug comes in the market?
So depending on, these are questions that you would ask the lab, whether they store the information. So unless a new pathway comes, but if it's any of the existing pathway, the new drug will just go the same way. So if, let's say, a new drug named ABC comes to the market, but it goes through the CYP2D6 pathway, then we already know that information. The patient doesn't need to be swabbed because we already know they are either an extensive or a non-metabolizer or a poor metabolizer of CYP2D6. So that can be added on their panel. But if a new pathway comes and it's a totally different gene that needs to be tested, then the patient would need a new swab. Otherwise, I'm not sure if any new pathway has come to market in the last, I don't know how many years.
Thank you. We have time for one more question, and this one says, how do you store this information to be used every time a patient is prescribed a medication or receives a medication in the pharmacy?
So in primary care, especially, now we have a lot of the electronic medical records that are building in what we call the clinical support, where you can upload all these tests in, and once the patient has received it, before prescribing, it helps with the clinical decision-making for the providers. So in the pharmacy side, this technology is being built in as well. Right now, for patients that we've received tests, have been placed in as the medications they cannot take completely, as if they're allergic to, and a level of, and these will be like highest level. Patients that could be intermediate metabolizer, and we just need to kind of be alerted and warned to counsel the patient and the provider. We'll put it in a category that it's still an allergy, but it's something we can override. And that's what we've used so far. But a lot of the dispensing softwares are expanding their abilities to be able to house this information. And every time a new prescription comes in, it would alert the pharmacist, just like it would alert any other drug-drug interaction. So yes, I'm excited that the technology is stepping up as well. So from clinical decision support in the EHR to housing this information for patients in their dispensing is sure going to improve how we prescribe and safer patients.
I would like to once again thank Amina Abubakar for her presentation. I would also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through August 2018. You'll receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thank you for joining us. We hope to see you again soon. Goodbye.
Thank you.